Thank you very much, sir. That was really enlightening, and we have really got a taste of the case-based presentation. Thank you very much. I am Dr. Haimanti Chaudhary from Silchar, Assam. I will be talking to you on operation theatre layout and sterilization. The first thing that we have to know is the 4 pillars on which an optimal OT stands is the location and building design, patient and space utilization, safety goals, and infection control. To that, we have to add some management issues, the equipment and medication management, personnel, HR, and staff training. Often the things that comes to our mind is why at all do we need an operation theatre layout? That is because we have to go by the approval of the government and the other professional bodies. It improves the service we give to the patients. It enhances the image of the hospital, and most importantly, it saves us from medical negligence. So in this talk, we will be covering the CME series that has been published by the ARC and distributed to all the AIOC members. It includes the NABH guidelines as well. NABH has categorized operation theatre into 2. One is the super specialty OT, another is the general OT. The ophthalmology comes under the general OT category. How to maintain the sterilization will be dealt under 2 headings. One is the infrastructure and engineering control, another being the managerial control. While we are planning a OT, we have to keep in mind that there should be functional segregation from the outpatient department, from the indoor, and also we would not want any laboratory air to get access into the operation theatre. Better to avoid the ground floor, we also want our OT to be free from contamination and cross-infection, and it goes without saying that the construction material should be long-lasting and resistant to microorganisms. Basically, an operation theatre complex has 4 zones. One is the protective zone, which houses the staff rooms and the recovery rooms. The clean zone is the intermediate between the protective and the sterile zone, and it houses the sterilization area. The 3rd zone is the heart of the operation theatre, which is the sterile zone, and the last is the disposal zone. An example of the protective zone, the clean zone, and the sterile zone. The ventilation in an operation theatre should have laminar airflow with HEPA filters, which should be efficient to the level of 0.3 microns. It should ensure air exchanges of 20 cycles per hour. But for those who cannot afford to have that, a central AC or a split AC is as good, but there is a strict no-no to fan usage and window AC. This is how an air handling unit looks like. The water tank should be a separate one for the IoT, and it should be cleaned once in a month, and that cleaning has to be maintained in a register or a logbook. These are the minimum standards that has been put forward by the NABH. The temperature, humidity, air handling, all needs to be maintained according to the prescribed guidelines. The occupancy should be limited to 8 persons, and even the equipment load should be limited to 7 kilowatt. The flooring should be seamless, it should be non-porous and smooth, and most importantly, it should be repeatedly cleanable easily. The walls should have an antibacterial and antifungal paint, dust-proof and moisture-proof. The door should have a self-closing device, and it is always a good idea to have a separate power supply for the costly machines like microscopes and phaco machines. All said and done, for entry-level ophthalmic surgeons who are just trying to open a new operation theatre, it might not be logical to think that they can afford a HEPA filter. So for them, any good system to maintain clean air and which ensures air exchange is acceptable. Of course, as I already said, a well-maintained split AC and a humidity maintainer will be good. This is the design of the central sterile supply unit, where the pressure has to be maintained in the negative Pressure will be maintained negative in the soiled zone and positive in the clean zone and the sterile zone. The flow of instruments and people will be only unidirectional. There will be no bidirectional movement of unsterile instruments. A three-dimensional view of the central sterile supply department. Modular OT, for those who can afford it, this is of course the best option because this has been designed with perfection. All the operation theaters should have a disinfection room because we can clean all the stuff here and it should not be mixed with other parts of the OT. Coming to the sterilization part, which is the most important, the reprocessing of surgical instrument is of utmost importance because often the source of infection is from our instruments. So there are certain rules that needs to be followed when we are doing the cleaning of the instrument. The cleaning should be done immediately after use. There should be a separate, dedicated cleaning staff who will be looking only after the cleaning department and not those staff who are assisting us in the OT. The blunt and sharp instruments should be separated. They are first rinsed in the distilled water, processed in the ultrasonic cleaner, and then cleaning is done by the 4-bowl technique. The first 2 bowls contain antiseptic solution, and the second 2 bowls, which are again the instruments are dipped into, contains distilled water. The sharp instruments tips are clogged with silicone plugs, and then they are dried and kept as set in stainless steel trays. The processing of hollow instruments is important because we have lot of, please come here. Yeah, okay. We have lot of hollow instruments in our vitrectomy, phaco machines. All the hollow instruments, the irrigation aspiration cannula as well as the phaco handpiece needs to be flushed with distilled water 3 times. That flushing, as you can see here, is being done with a 60 cc syringe and not a 10 cc syringe. Thrice we'll flush with distilled water, we'll throw that distilled water, and thrice the flushing will be done by air. So that makes a 6 times flushing. After the instruments have been washed, cleaned and scrubbed, we want to dry it. The drying in our OT is done by a hair dryer because any amount of moisture left behind often causes rusting and we do not want the instrument life to be lessened. So we dry all our instruments with a hair dryer. After that is done, it is packed. The packing is separate for steam autoclave and for ethylene oxide. For steam autoclave, the packing is with linen, double layered linen, and on each layer, the chemical indicator strip are attached and date and time is written on that. And for ethylene oxide, the packing is separate, which have indicators which change color after the sterilization process. Most of the linen and metallic instruments are done on a horizontal autoclave. A vertical autoclave is not preferred because this has no vacuum system. All the autoclave instruments should be used within 48 hours and autoclave logbook must be maintained. For heat labile instruments like tubings, vitrectomy cutters, lenses, ethylene oxide gas sterilizer is used. It takes usually 6 hours, but since the gas is quite toxic, so an aeration period of 72 hours is required. This is just a glimpse of the ethylene oxide sterilizer. The instruments are individually packed. They are put inside the ETO machine. An amount of moisture is put. It is locked. The vacuum is activated. The temperature is set. And when the requisite temperature has been set, the machine will be turned off after 6 hours. How do we know that our sterilization is up to the mark? This has to be validated with different indicators like physical, chemical, and biological indicators. Now coming to the operation room and corridor cleaning, some part of it has been covered by my previous speaker, but still I'll repeat few things because these are very important. No dry dusting, as has already been mentioned, wet mopping with bacillocid, and formalin fumigation, though it is not preferred by the CDC, but still many of the OTs are still continuing with the formalin fumigation. It can be done in two ways, either aerosol spray, or if aerosol spray is not available, it can be done by mixing with potassium permanganate, and on the next morning, the fumes are neutralized with liquid ammonia. For a running OT, fumigation should be done once a week. For someone who is a startup OT, fumigation needs to be done on 3 consecutive days, and 3 negative culture needs to be attained. There are certain new devices, as has been mentioned, like Alkadol, bacillocid, and all the fumigation process should be documented. We do the cleaning with a 3-bucket approach, where the first bucket contains the water, the second one contains an antiseptic solution, and the third bucket contains bacillocid. This is the cleaning protocol. The roof cleaned 3 monthly, wall and floor daily. The refrigerator should be cleaned weekly. The sink and all the OT furnitures will be cleaned daily, and the HEPA filters will be cleaned 3 monthly. Thank you very much for your kind attention.